Welcome and thank you for joining this week's webinar in the COVID-19 and Humanitarian Settings Knowledge and Experience Sharing webinar series. During this webinar, participant microphones have been muted. However, we do encourage you to make use of the chat box to communicate with the presenters and to ask questions. Access to today's recording will be available after the webinar at readyinitiative.org and on the Johns Hopkins Center for Communication Programs YouTube page. It is now my pleasure to introduce our moderator for today, Associate Vice President for Gender Equality at Save the Children, Yeva Avakyan.
Good morning, and thank you, Ryan. We know that COVID-19 pandemic is amplifying and exacerbating inequalities around the world. There is no shortage of examples, from increased risk of gender-based violence, decreasing access to sexual reproductive health services, increased burden of care, economic ramifications that are hitting a massive proportion of women in the informal economy, and the future impacts that we can predict based on previous crises and from our own lived experiences, and how crises such as this can expose the cracks in our system. This includes potential risk of girls not returning back to school, which we've seen after the Ebola outbreak, and even some anecdotal evidence recently about that harmful practices such as female genital mutilation is back on the rise in some communities. And when we talk about lessons learned and what we need to be aware of in responding to this pandemic is the lessons that we as community have often ignored. And the lesson is that we weren't in a great place before the pandemic, and that this crisis will expose and exacerbate existing gender inequalities. That's one of the lessons. And so it is my absolute pleasure to introduce you to this wonderful panel that will be speaking today and start a conversation about how COVID-19 exacerbates gender inequalities. First, I'd like to introduce Dr. Michelle Lokot, who is the research fellow at London School of Hygiene and Tropical Medicine with the Gender Violence and Health Center. She has a PhD in gender studies, a master's in international community development, bachelor's degree in law, and has worked as a humanitarian worker, focusing on gender equality and women's empowerment issues, and provides technical support and guidance to NGOs on improving gender equality and LGBT in their programming. Next is Alina Potts, who is a research scientist with the Global Women's Institute at the George Washington University. She's a practitioner and researcher with much experience responding to gender-based violence in emergencies and efforts to prevent it. She leads the Empowered 8 project, participatory action research with women and girls living as refugees in Lebanon and Uganda to mitigate the risk of sexual exploitation and abuse. Dorcas Auchen is Save the Children's Gender Equality and Gender-Based Violence Advisor for East and Southern Africa Regional Office. And Dorcas specializes in gender-based violence prevention, risk mitigation, emergency preparedness and response. She holds a master's in gender and development, MA in economics, decades experience in Uganda, Rwanda, Kenya, South Sudan, Zambia, and Ethiopia. And then last but not least, Cansu Aydin with CARE International in Iraq. She's a gender and protection manager, and she specializes in gender and gender-based violence in humanitarian and development contexts. She's particularly passionate about understanding and addressing gender inequality and in emergencies. As a previous Fulbright Scholarship grantee, she holds Masters in Public Administration with a focus on human rights and social justice. So welcome everyone. And I'm going to ask my first question to Michelle. Michelle, you've been very outspoken about the importance of feminist research, and especially as it relates to the context of COVID-19. Tell us, what does it mean to have a feminist lens in understanding the COVID-19 pandemic, and how can it help us understand power hierarchies and inequalities that have been magnified during this crisis?
Thanks, Yeva. So I'm going to just start with a quick overview of what it means to take a feminist approach. And so I think at its heart, a feminist approach is about making women's lives better. And so in order to improve women's lives, feminist approaches challenge the intersectional power hierarchies that structure women's lives and that negatively affect them. And so this involves doing intersectional analysis, looking at the intersecting oppressions and identities like gender and race, migrant status, economic status, and how these intersect to shape people's lives. Feminist approaches are also very reflexive. So they focus on the power, the position of the implementer, the researcher, the organization, looking at how our background, our experience, and our worldviews might shape how we work and how it might also influence our motivations. And so with this sort of broad framing, thinking about women being at the heart of it, of power, intersectionality, and reflexivity, today I thought I would speak about the issue of data collection. And I think a feminist perspective is really valuable in thinking about data collection during this period. It's been really encouraging to see so much emphasis on the need to represent women's lives and women's voices, which has been missing from a lot of the previous emergencies. And so this is really important. But I think it's also important to recognize that more data isn't necessarily always the answer. So we need right data. We need data that is meaningful for women. I think we often collect more data than we need, and we don't do enough with the data that we do have. What we've seen is that during this crisis, many NGOs have been trying to collect data on the prevalence of gender-based violence. And from a feminist perspective, this can raise some concerns. We have our gender-based violence guidelines, which have come from the Interagency Standing Committee on Violence During Emergencies. And these guidelines state that gender-based violence is happening everywhere, whether or not the prevalence is known. And that we shouldn't necessarily be collecting data to prove that gender-based violence is occurring, because it is occurring, and we know it is. I think that during the pandemic, it can be quite difficult to safely collect data on violence from women. Women might be at home with their perpetrators, and this makes it more difficult to minimize breaches of confidentiality, to ensure that women are able to provide informed consent. When we think about our violence research, even in a normal situation where we have face-to-face data collection, it can be really challenging. And these challenges are magnified when we use remote data collection methods. Some NGOs have been using SMS, text messages, to collect data on violence. But this can be quite risky as well, because women are not always the sole users of their phones. Telephones might be shared in between family members. And importantly, phone data collection may exclude the poorest women who don't have access to phones. And so some of these challenges need to inform our data collection, the choices that we make about data collection. And some broad questions to think about might be, why do we need this data? And is it worth the risk to women? A feminist approach also looks at the motivations behind data collection. And so here is where reflexivity and sort of looking inward a little bit becomes really important. If we're collecting data because we're trying to prove that gender-based violence is a problem, or because every other NGO has released something on COVID and we should as well, then possibly women are not at the heart of it. And so a feminist approach looks at what's important, what's relevant for communities themselves. I think so often we choose the issues to focus on, and these might not be the most pressing ones for communities. And so thinking about what data is actually important when we think about gender-based violence. It might be data about disruptions to services, about stigma among service providers, and this data can make a huge difference to the lives of women. And then thinking about who do we engage when we conduct our gender assessments. Often we use key informants in our research. And this can be problematic from a feminist perspective because of the power and the privilege that surrounds key informants. Key informants are often power holders, they're community leaders, they're decision makers, and they're most often men. The assumption is that they represent their communities when in fact these might be the elite of the community. And the research method itself of a key informant interview actually allows a lot more freedom for the participant than other research methods. We think about focus group discussions where people's contributions might be limited, or survey questions where it's a multiple choice option, whereas key informants can even steer the conversation, they can ask open-ended questions. questions, and they can talk freely about their views. And so then the feminist question becomes about whose knowledge is valued and whose voices dominate. Who are we listening to as we engage in preparedness and as we engage in decision-making on COVID? At times, expert data or hard data might be valued over experiential data, over the experiences of communities. At times, quantitative data might be valued over qualitative data. And lastly, do we close the loop in our data collection? I think especially during emergencies, Julia Smith talks about this tyranny of the urgent and how this emergency mode might affect how we collect data. We might be more extractive rather than valuing the time of communities and our relationships with them. It can be easy in an emergency not to close the loop, not to feed back the findings to communities, but that is a vital part of a feminist approach. Thanks, Yeva.
Thanks, Michelle. And indeed, more data is not always the answer, and the right data, the right approaches to collecting that data is what we need right now. I want to turn to Alina, and as we heard, this pandemic has exacerbated the risk of gender-based violence. In your research, you outline 9 different pathways in which violence against women is linked to pandemics. Can you tell us about your findings, and particularly about situating violence against women and children within the broader need of intersectional and feminist-informed pandemic response? Thank you. You're on mute.
Okay, is that better?
Yes.
All right, thank you. So I'm happy to do that, and thanks everybody for coming together around this topic. I'll share relatively briefly findings from a rapid review that was done after conversations in the Gender and COVID-19 Working Group, which came together rather quickly, and it's an interdisciplinary group across institutions to really share knowledge and resources and try to get information out quickly so we can do, as Michelle said, and really make better use of the data we have. And inform what we're going to do based on what's happened before. So this was looking at pandemics and large-scale public health emergencies, and also at violence against women as well as violence against children, which intersect in many ways. 9 indirect and direct pathways were identified, which you can see here. There's a lot of interactions and reinforcements between these. I'll go through them relatively quickly. The first is economic insecurity and poverty-related stress. So there's quite a large body of literature linking poverty, housing insecurity, unemployment, food insecurity, all the things that we're seeing now in high, middle, and low-income countries, as well as associated what are called negative coping strategies. So ways that people often deal with these devastating life experiences and stressors that are linked to violence against women and children. The second is quarantines and social isolation. So again, this can be linked to problematic coping behaviors, poor mental health, and also increased day-to-day exposure and reinforced isolation for those already facing violence by partners or parents, in their homes, which now that it's harder to escape from, or to have temporary escape from. The third is disaster and conflict-related unrest and instability. So in these settings, we can see, often social support networks and services are already under strain, already affected. Many times families can be separated or living displaced from their homes. And so again, we can see how that intersecting with the pandemic can lead to potentially pathways to violence. The fourth is exposure to exploitative relationships due to changing demographics. And this relates to how increased mortality and morbidity may leave children, and particularly adolescent girls, more vulnerable to exploitation from extended caregiving relationships or relationships with older men. There's some really powerful research documenting this in the Ebola response, for example. The fifth is reduced health service availability and access to first responders. And this links to how increased strain on the healthcare setting can really stop or reduce demand for other services. So for example, sexual and reproductive health services. Funding may be redirected to COVID-19. users may be afraid, women, girls who need these services, need antenatal care, may be afraid to go to a health setting for fear of getting infected. There's also virus-specific sources of violence. So this links to how fear around transmission may create an enabling environment for misinformation, scare tactics, controlling behaviors such as withholding treatment or financial support of necessary safety items in abusive relationships. Taking an intersectional lens, for example, here we can see that viruses that can be transmitted sexually have been linked to violence upon disclosure. So disclosure of one's status, for example, HIV/AIDS, and stigmatization. So we saw that happen a lot in the HIV/AIDS pandemic and among the LGBTQ community. And then viruses linked to, for example, disability may increase risk of violence. So we can see that with the Zika. We have next the inability of women to temporarily escape abusive partners. So again, there's limited physical mobility. Often in my own experience working directly with survivors and providing services, and I'm sure many of you do this as well, making a safety plan, thinking of where to go, thinking of who to contact, that's much harder in these circumstances, as well as access to legal and other supports may be impossible. Exposure to violence and response efforts. So this links to sexual exploitation and abuse, which I'll talk about a bit later as well, arising from unequal power dynamics. So for example, aid workers, water truck drivers, contractors. In Ebola, there are documented cases even among members of burial teams and vaccination teams in which they use their power to bring necessary resources to that community to instead exploit people in need. And finally, violence against healthcare workers. So women are 70% of the global health workforce. If disaggregated further, we would see probably even further disparities among that number. And the pandemics can magnify the violence and harassment they already face. So because of time, I'm not going to get into the details. I'm not going to be able to get into the details of this, but the full paper and a summary is available on the Center for Global Development website. You can see we've outlined program and policy responses, and I do just before finishing want to emphasize that there's a real need within our responses to work not only with individuals and communities, but also to address structural inequalities. So without getting too jargony, basically, what are the social or economic or political systems that these individuals and communities exist within that actively exclude them, and how in our responses can we change or transform these systems to be more accountable and inclusive? And I would just say really importantly, how do we recognize our own roles, even inadvertently in these systems, and as aid actors bringing in resources. Doing this with the feminist intersectional lens means constantly asking who has access to these resources, who can control them, who is being left out, and asking these questions with the people most affected rather than without them. So the responses here outline some ways to better prevent and respond to violence and can be further contextualized. So thank you, Yeva.
Thanks so much, Alina. And indeed, the measures that we put in place to protect populations from the virus can have very detrimental consequences for women and children in the household in terms of risk of violence. And thanks for outlining the pathways and some of the recommendations for policy and action. I want to now turn to Jansu and Dorcas, and you're both working in organizations that are really carefully and thoroughly thinking through the response to make sure that the work is informed by analysis of gender inequalities. And so what are you learning about COVID-19 and its impact on gender inequality in your context? And what are some of the things that we're seeing right now from the field? And Jansu, I'll start with you. No, you're on mute.
Better now?
Yeah.
Okay. Thanks, Yeva, and thanks, Alina and Michelle, for the technical framework they have drawn. All emergency situations, including disease outbreaks, affect women and men differently. And pandemics are known to exacerbate existing inequalities for women and girls and discrimination of other marginalized groups. And pandemic COVID-19 exacerbates, feeds the so-called shadow pandemic, the gender-based violence in Iraq. We not only witness increase in number of women and girls seeking assistance through phone consultations, but also hearing from other organizations that number of calls on GBV and domestic violence hotlines have increased after the lockdown. I can say that since January, the number of women and girls reaching out for psychosocial support due to psychological abuse almost doubled. The average family size in Iraq is 7.7, and people are stuck inside crowded houses, and families are sometimes separated, residing in different governorates. And COVID-19 lockdown measures reportedly increased domestic violence, as women who consult our psychologists indicated that lack of freedom to go out, lack of freedom of movement caused tensions among couples and within households. There seems to be a feeling of constant threat within the households, and frustration and disagreements can easily turn into result into some sort of violence. So we clearly see a pattern of lack of social activities and financial pressures increasing violence at home in Iraq. We also hear that self-immolation, self-inflicted injuries due to spousal abuse, sexual harassment of minors, suicide, and transactional sex are also becoming common risks. The inter-household tension is increasing due to loss of livelihoods, and there are many community members reaching out to NGOs, seeking help with accessing livelihoods opportunities or vocational trainings. Furthermore, women and girls are exposed to multiple caregiving burdens that lead to greater physical and mental health risks. I think this is a common phenomenon throughout the world, but it's the same in Iraq. They are usually responsible from prevention and response efforts at home, and therefore at a higher risk of infection and of emotional, social, and socioeconomic harm. Girls and women are also disproportionately affected by these crises, as it's culturally unacceptable to put women and girls in mixed gender spaces without relatives. So there is less opportunity for them to seek out support, not only for COVID-19 response, but also for sexual and reproductive health services. Besides, the health services are already overwhelmed with the COVID-19 response. Access to GBV services can occasionally be disrupted. In an assessment that we conducted at the end of March, we found that refugees, internally displaced people, female-headed households, older men and women, people with specialized needs, people with disabilities were perceived to be more vulnerable to this crisis. Also, we saw the importance of intersectional approach, as Michelle was emphasizing. For instance, the community members were indicating that a refugee woman or IDP woman or a girl was much more vulnerable in our current context. And for older populations, the crisis seemed to also have higher risks attached, and they are more marginalized as their access to technology, social media, or phones seems to be more limited. And this is also valid for girls whose access to mobile phones are either restricted or monitored by their caregivers. And lastly, this brings me to the gender technology gap. As sessions and services now are delivered mainly through online platforms, we see that women and girls have less access to technological equipment and hence can participate less in processes, participate or exert leadership in crisis, and benefit less from the online services. Over to you, Yeva.
Thanks so much, Cansu. Really important to have that lens in understanding where and how the crisis hits different groups. Dorcas, what about you? What are some of the observations that you're seeing from where you are?
Yeah, thank you so much, Yeva and the team. From where I sit in East and Southern Africa, I would put forward, adding to what my colleague Cansu has already put across, about three things. First, we've seen increase in the number of cases of GBV much more generally, but specifically issues around harmful traditional practices, such as female genital mutilation. And this is cutting across in most of the country offices, like Somalia, parts of Kenya, Sudan, and also Mozambique, where we work with anti-female genital mutilation groups. And we've seen, looking at the pre-COVID-19 period, and also the current situation, we've seen not just increase in numbers, but also severity in the kind of cases that we are receiving currently. And in some of those locations where we used to receive about 3 to 4 cases per month, we've seen the number has risen to similar number of cases on a weekly basis. And also the forms are much more severe, with some of them involving complete cutting of the labia, and yet the girls are finding it very challenging to access medical services. And also the second is around increase in domestic violence, much more generally, but specifically intimate partner violence. Again, in most of the countries within East and Southern Africa. For example, in Kenya, recently the government reported about 36% increase in the reported cases of gender-based violence, most especially intimate partner violence again. And this is cutting across the urban settings, but also especially the remote areas, including the camp settings. And within the camp settings and also remote areas, we've also seen rise in teenage pregnancy coupled with forced marriage. And this is also coupled with limited access to available services, with a lot of restrictions in movements due to the lockdown. And survivors find it really challenging to be able to access available services. Even locations where we recently have referral pathways updated with the COVID-19 response. But again, even with those referral mechanisms in place and also updated, still it is increasingly becoming very challenging for teams, for survivors, to be able to navigate the referral mechanisms and access the different services. And also around access to sexual and reproductive health services. As the third, we've also seen a lot of challenges where we're receiving a lot of reports increasingly on women and also adolescent girls finding it very challenging to access the available sexual and reproductive health services. This has already been challenging even before the COVID-19 pandemic. And now with the restricted movements around due to the lockdown and curfews, it has even become much more challenging. And we've seen, for example, in areas like in Uganda, where we're having even more maternal mortality, we've had cases of women giving birth along the routes as they try to access the health facilities to be able to access the medical services. And the other last bit is around inequitable access to information for different groups of people within the communities. And this is affecting mostly women and girls because of the nature of the work or the burden of care that they have to go through during the day. And some of the cases or some of the information that goes out, including those around education where children are learning from TV and radio programs. Again, we've had challenges where girls report that they hardly find time to participate in those, but also more generally, women and girls having to be able to access valuable information that is being passed across through radios and also TVs. Thank you, and over to you back, Yeva.
Thanks so much, Dorcas. And yeah, it is really sad to hear that the increase in frequency and intensity of both gender-based violence, but also continued restricting access to services. I wanted to ask the following question to all panelists, and we will go in the reverse order this time. Dorcas, I'll call back on you. What are some of the biggest challenges that you're seeing as researchers and practitioners in ensuring the response to COVID-19 is gender equitable and that we're not doing harm? What are some of the lessons learned and practical suggestions that you can offer to the audience from what you're learning? Dorcas.
Yes, thank you once again, Yeva. So I would be able to pick at least about 2 or 3 top line items, which we are doing and we've seen are working, and also what we are advocating for. First is around the importance and the need for agencies to be able to conduct a rapid gender analysis, and also ensuring that the plans, the response plans for COVID-19 for different agencies, like what Save the Children is doing in some of the country offices, is aligning with the government response plans, and also to ensure that the government line ministries are also able to apply the gender lens in the government response plans as a starting point. But also, because that will help us to be able to target, but also for responses to benefit different categories of women, men, boys, and girls of different age groups, and also different disability status. But also the other is around the need to coordinate the national and the local responses so that they can speak to each other. And also in locations, for example, where we have the gender and family and child protection units within the local settings, to be part of the local level, but also part of the national COVID-19 response. And this is something which in some of the locations where we've had to push for, we've seen working. And of course, in some of the areas, we are not yet seeing it working very well, but it's something worth doing. And then the other is around the social protection mechanisms. In some of the locations where Save the Children is providing cash transfers to vulnerable communities in form of unconditional cash grants. And I think also we've seen this working well, appreciated by the communities, and increasingly the need to be able to push for similar approaches to different agencies, but also the government line ministries, to be able to support households, especially vulnerable households with female caretakers, and also households with children who are caretakers, besides the food, which is prioritized by some of the government line ministries. And then the third is around ensuring continuity of gender-related services, especially where we see the services around sexual and reproductive health, and also other gender-based violence services lagging behind. The need for the teams to be able to push those to be part of the essential services within the COVID-19 response, and also advocating for different agencies and also government to consider them as such, as part of the essential services, even during the lockdown. I think that would help so much to be able to push those right from the national level up to the local level, to broaden the government guidelines on essential service providers who can cover and also who can handle cases of GBV, service providers such as counselors, psychosocial support staff, and also those providing shelters for some of the survivors who might wish to find a place where they can be accommodated temporarily while different services are being navigated. And also this along, of course, besides the medical teams, who are at least in most of the cases being prioritized already, but there is a gap in the staff who are providing psychosocial support. So I think majorly those, and if those can be included, and also for the curfew guidelines to ensure safe passage, especially during the curfew hours for such emergencies like women in labor, and also survivors who would wish to access gender-based violence services. Thank you.
Thanks so much, Dorcas. Very important points. Jansu, what about you?
Thanks, Yeva. I really think it's vital to talk about these challenges and provide practical suggestions to other colleagues who are working in different field locations. I would like to mention 2 things. The first one is the localization. Localization has been on the agenda of humanitarian actors for a while, but after COVID-19, it has been even proven to be more important than we thought before. While many international organizations are having restrictions in reaching out to communities, in remote areas, and local organizations are embedded in communities, and they can be a better place to continue providing support when the others cannot. The restrictions on travel and additional constraints to international agencies pose opportunities for the humanitarian actors, humanitarian system, to advance on commitments to localize the aid. So I think it's really important to think about it. And particularly partnerships with local women's organizations who can ensure that women and girls are leading in their own communities and they stand up for their rights and they lead the aid in their own communities can be a really important suggestion. And furthermore, the previous health crisis also shown that health-related operations also could lead to a mistrust with the communities if the culture of the community is not taken into account. So the community groups or local organizations would be in a really good place to understand those cultural dynamics or social norms than the international organizations. And second, I would like to talk about briefly the data collection. In order to understand the changing social norms and impact of the crisis on women, girls, men and boys, there is a need to undertake a gender analysis, which would also inform us about the capacities, capabilities, and special protection needs of the various groups in the communities. Some of the challenges we faced in conducting assessments or analysis were around data collection or access to field. And I bet it's one of the main challenges people are facing now in various locations. Some of the practical tips to overcome these challenges could be focusing more on remote data collection through key informant interviews or phone interviews with the existing beneficiary based on the existing beneficiary databases and avoiding focus group discussions. I would like to refer also to Michelle's point on choosing your key informant interviews in a manner that doesn't prioritize those in power positions over the communities who could speak up for themselves as well. So it's really important to also consider these power dynamics and empowerment of the communities to stand up for their own rights and speak for themselves. And since primary data collection seems challenging now, it's definitely recommended to coordinate with local coordination groups, such as working groups in your area or the cluster, to see what kind of assessments are already undertaken or available, so you don't duplicate or make another assessment on the same topic. And focus only on what is a must to know or need to know information rather than trying to cover everything in one assessment. It's better to focus on what we really need to know to respond to the crisis. And therefore to try to design tools that you can finish up in 10 to 15 minutes through phone. Because phone interviews usually take up to 25 or 4% more than regular interviews. Because when you are doing face-to-face assessments, you have the opportunity to show through your gestures or to explain better what you are looking for. But through phone, you would need more time to explain yourself or clarify your questions and so on. So that's all, I think. Over to you, Yeva.
Thanks so much, Jan. So lots of very important points, from localization to partnerships with local NGOs, to understanding government response plans and aligning them with the broader NGO community plans and continuity of services. Alina, what about you? What are some of your reflections?
Sure, thank you, Yeva. I'd like to share two main reflections, and these are coming from Empowered Aid, so one of the main projects that I work on. And the first one is around, just the importance of knowing that violence is happening, whether we can see it or measure it or not. This is a quote from one of the adolescent girls that is part of our research team in Uganda. And she says, "At times you find that we girls or women, we find difficulties with the distributors. They come and tell that if you fall in love with me, I will add more food, or for the cooking oil, you will get a big share." So you end up, after they have realized the food is about to come, they move around cornering girls or women that if you really fall in love with me, I will add you food. So those are big challenges. So this speaks to the possibilities for sexual exploitation and abuse that I mentioned earlier. And again, this is when someone's asking for sex in exchange for goods or services, things that should be offered freely. And it's really important to know that, now in the context of COVID-19, there may be even more items being distributed more dependency on these items and also less oversight, right? And particularly if we think of things like having women aid workers present, you know, ensuring that there are open complaints mechanisms, things that the women and girls that we worked with in Uganda and Lebanon tell us are important. Those might be even harder for them to access. So how do we proactively take steps to do that? The IESC released interim technical guidance on prevention of SCA in the context of COVID-19. And one thing we've been doing is ensuring that we, this is participatory action research, but it's really focused on also you know, making sure that we, in our own work to distribute dignity kits, for example, we are distributing those now, and we're really only collecting the necessary data to monitor those distributions accountably, right? As we've said many times, it's not the time to kind of ask a lot of extra questions or things that we can find out elsewhere, but it is important to hold ourselves accountable. And I think that's my second main reflection, which, you know, we keep touching on, is really around thinking about participation and power more broadly, and thinking about ourselves within that, right? And putting ourselves within that. And recognizing that women and children, even in the midst of a pandemic, we want to work with diverse members of those groups in participatory ways, because they're experts on their own lives. They're experts on what's going on right now. And women's organizations, children's protection networks, they've been strategizing for many years about how to support people in the face of constrained resources and constrained access. So they really know a lot about this. So how can we work with them, better localize, also take the onus so that we don't have, you know, if we are going to these organizations, we're going in coordinated ways that don't overburden them at this time, and that in our partnerships, we're, you know, reducing the red tape, we're funding freely. We have some great examples from the Ebola response of how, you know, that kind of funding and that kind of flexibility allowed service providers to really iterate and learn and be flexible. And taking an assets approach means recognizing that there's a lot of expertise out there, and we need to ensure that our systems are allowing it the freedom it needs to respond. So we can see this with, again, with examples from Ebola and how women's centers, for example, that were able to provide services in different ways, or, you know, move staff around, or maybe change the way that they provided case management, were able to keep going and even see an increase in access at times when other centers were seeing decreased use. So I'll stop there. Thanks.
Thank you, Alina. Lots of food for thought here on data and holding ourselves accountable. Michelle, what about you?
Thanks, Yeva. I think just to add to the great suggestions that have come from the others, I think for me, thinking about how we depict and how we represent the challenges of communities during this period. I think in the last couple of weeks and months, we've seen a lot of news articles and advertisements, reports from NGOs about the coronavirus. And they sometimes represent the lives of people living in these development and humanitarian contexts in sort of quite stereotypical ways. So without recognition of the resilience they already have, of their dignity. And so I think even thinking about how even our well-intentioned representations may cause harm, I think there's sometimes a temptation to present quite emotive issues like child marriage or violence against women or girls in very sensationalist ways, or using the current buzzwords to generate funding and interest. And so I think taking care in how we mobilize these buzzwords and this language, and then coming back to this question, are women at the heart of it? I think also when it comes to the language that we use to talk about gender and COVID, sometimes the kind of stereotypes that we end up resorting to. So for example, a lot of reports refer to the vulnerability of women and girls. And so this language around vulnerability in women and girls is often quite vague and non-specific. It assumes, it imposes vulnerability on women and girls as if they're a uniform group. And so in this kind of framing, we miss men's vulnerability. We miss the intersections between race and education level and economic status, disability and other factors. So I think it's not just about women and girls, but what about, you know, how COVID impacts an adolescent girl who's living in a refugee camp and has a disability. So I think that is important. Dorcas talked about equitable access to information and how important that is. And we know from other epidemics that people with lower literacy face higher rates of infection. And so when women make up 2/3 of the world's non-literate population, how does that affect the COVID prevention messaging that we share with communities? How does that affect our interventions? So I think the challenge for us is thinking about how to move away from reducing complex power hierarchies and intersecting oppressions to this sort of quite watery label of vulnerable groups. I think it's more helpful to talk about power and to situate it in power. And so there are frameworks for power that people might find helpful. Patricia Hill Collins has done a lot of work on this, building on her work on Black feminist thought to come up with a framework for domination, which is a really useful way of thinking about power. John Gaventa's work on visible, invisible, and hidden power is also, I think, a really helpful way of framing the way that we think about these oppressions. And so I think for us as practitioners, as researchers, thinking about how we look at power instead of reducing it to sort of a label of vulnerable groups. And that might be a more productive, a more feminist way of analyzing these issues. Thanks, Yeva.
Thanks so much, Michelle. You're raising very important questions about how we portray very complex issues in our research and practice. We have a few questions and we have about 14 minutes left for our time. So what I'm going to do is I will read out top 5 questions, and then we'll do another round of responses. And so feel free to respond to the question that speaks to you. So some of the questions that we are receiving are around, social and cultural norms that have a strong influence in responding to gender-based violence, and which also gets heightened with the restrictions during pandemic. How is that addressed in the 9 pathways mentioned earlier? I think that's a question to you, Alina. And then what is the situation of women's access to justice in countries where you've been working? Not just victims, survivors of GBV, but also women in detention. Are protection orders still being issued and court hearings ongoing, maybe virtual? Can marginalized women who have been abused by partner, also by police when arrested for quarantine offenses, or access specific services? So, so access to services, what kind of services in times of isolation? A feminist approach to gender mainstreaming has been institutionalized by many international organizations. How can gender mainstreaming be incorporated in the response to COVID-19 beyond just collecting disaggregated data? And how can these responses be implemented in the context of a non-secular low-income countries? And then lastly, a question about, still haven't heard any data with respect to men. What have the panelists found with respect to men's issues in context of COVID-19? All right, does anyone want to start or respond to any of these?
I'm happy to start, Yeva.
Mm-hmm.
Yeah, so, and I'm sorry, I was just typing a response to Neha's question in the chat. So the question about norms, great question. I can direct you to the full paper. I'll pop that link in the chat as well. And there's many good resources now coming out on around COVID-19. So that's by far and away not the only one. So I'll also direct you to great repositories that I use. Are the Gender-Based Violence Area of Responsibility website, and also the Gender-Based Violence Guidelines, the ISC Guidelines for Humanitarian Settings website. Both have great sections on COVID-19 that are constantly updated and have a lot of really practical tools and guidance. So I'll put those links in the chat. I will say in the paper, for example, a lot of the things I shared, I was sharing the very top level. We go through and give examples, and we can see, of course, how norms, gender norms, social norms can affect the types of pathways that I spoke about. And so one example would be around the link between analyses of unemployment. So on looking at male unemployment, female unemployment, and violence. And a global review found, and I was actually just quickly looking to make sure that I got the numbers right for you. But on a global level, an examination found that a 1% increase in male unemployment is associated with a 0.5 percentage point increase in physical IPV, which is intimate partner violence, for women, whereas increases in female unemployment were associated with decreases in intimate partner violence. That was a global review. On the other hand, for example, looking specifically in the United Kingdom, a paper published in 2016 found the opposite relationship. And then also, further looking at norms, there's a great example from Spain of a study that found that the relationship between unemployment and intimate partner violence really depended on both family structure and also past cultural norms within the family. So in settings with traditionally nuclear families, a decrease in female unemployment relative to male unemployment increased intimate partner violence, whereas the opposite was found in what are more traditional settings, large extended families where domestic work was shared by many people. So that's just a taste of how much these findings need to be contextualized. We aim to gather a lot of those examples in the paper, and I really encourage you to look and see what you find as well. I'll put a bunch of links in the chat for those that are interested to learn more. So I'll leave that there. I also Yeva, there's the question around access to courts and justice. I can give some examples from Lebanon also, if that would be useful when we get to that question.
Please go ahead.
Sure. Okay. So some of the work that we do in Lebanon extends to working with women's organizations there who provide support to women in detention. And so I quickly messaged one of them to ask her for the latest. And she said that the courts are still active in conducting investigations and testimonies virtually. They've been issuing virtual protection orders as well. The police keep receiving complaints with regards to domestic violence and other forms of abuse and intervening when necessary. There have been no new arrests for petty crimes implemented. So for example, women in prostitution, which is a group of women that we work with, many of whom have been also trafficked, or migrant women. So these are women from other countries who come to work domestically in people's houses, who have no legal documentation. They are no longer arrested in this current period, and penalties have been waived. And then some organizations who have outreach activities at detention centers have been providing online socio-legal counseling to detained women. So those are a few examples from the Lebanon context.
Thanks, Alina. Other panelists, any reflections? Johnson.
Yeah, so I would like to respond to Neil. I hope I pronounced your name correct. Men, definitely you are right. I mean, men are under a lot of pressure and they are facing challenges due to loss of jobs in Iraqi context. And you might recall that I mentioned there were some people reaching out to us to sort of benefit from livelihoods projects or vocational programs. And most of those beneficiaries were actually men. So definitely a good point. Thank you for raising that point. But also, unfortunately, we haven't done any research related to smoking habits. That's also a good point and perhaps worth exploring in different contexts. I also want to respond to the question about remote support. This is not from Care International, but it's from UNICEF. You might be aware of the new research piece that they published a couple of weeks ago. It was called Not Just Hotlines and Mobile Phones. They were talking about establishing phone booths in the centers where survivors could come and without dialing numbers, they could directly be connected to the social workers. So when in the context where, let's say, women and girls have technology gap in accessing technology, they could be easily accessing to sort of psychological support, psychosocial support. And lastly, ensuring women's voices and leadership was also, I think, another question I saw in the chat box. I think it's a really, it definitely depends on the context, but I think the opportunity lies on how we can capitalize how women and girls are already communicating in their own context. So this could depend or change from context to context, but we need to find out how women and girls are already communicating in our context and capitalize on that. So they can pass information to each other or sort of engage each other in the discussions that we are leading or activities that we are providing. Over to you, Yeva.
Thanks, Michelle. Johnson, sorry, Michelle.
Yeah, so just to add to what Jansu has suggested, there's also a resource that came out last week on remote data collection on violence against women during COVID, released by UNICEF. I think it was written by Amia Bhatia, by Amber Peterman and others. I'll share the link below, and that talks about some of the ethics around data collection during this period, and really unpack some of the considerations people should be thinking about as they're moving to remote data collection. And then just on the question about gender mainstreaming, yes, I think definitely it's about more than just disaggregating data, but conducting what we talked about, that intersectional analysis. I think, unfortunately, the language of gender mainstreaming is used a lot, but sometimes in quite a tokenistic way. And so in some ways, the term has become a little bit redundant and people have started talking about other things like power or intersectionality. There are, however, a lot of gender mainstreaming resources online with tools that can help with analysis. And these are quite practical tools that help you think about, you know, who has access to resources, who is making decisions, how are resources allocated, looking at some of the institutional inequalities around policies and structures that might influence sort of gender inequality, and then also things like division of labor, household inequality, looking at markets, so all kinds of different tools and resources that you might find useful. And then also I just wanted to talk to the question, I think in the chat, about gender-based violence and sort of what can be done to protect women who experience violence during this time. There are some really great resources that have been released by the GBV-IMS, the Gender-Based Violence Information Management System. So they have a podcast and they have videos and guidance materials that talk about gender-based violence generally, as well as during this period. And they emphasize the importance of ensuring that women have support and case management support, women who are already experiencing violence and who are receiving sort of counseling or help from a caseworker or a social worker, that they're able to access ongoing safety planning. They're able to sort of revise their safety plan to talk about how they might mitigate against violence, even practical things like what is the safest place in the home, what are the other support mechanisms around that household that they might be able to draw on, making a plan if a woman decides to leave. And so there are lots of really practical tools that talk through these issues on that GBV-IMS website that might be useful. Thanks, Yeva.
Thank you, Michelle. Dorcas, do you have any reflections? You have about 1 minute, please.
Yeah, thank you so much, Yeva. On some of the questions that I've seen around limited access, especially in locations where we don't have safe homes or safe shelters. From my interaction with the field teams and what we've seen working out is also linked to some of the things which we mentioned earlier around working very closely with some of the women's groups or existing women's rights organizations who have existing networks and teams within the communities even during this lockdown. And therefore, the locally led solutions coming from the women themselves, from the women's groups, in terms of finding alternative places for accommodation temporarily within the local settings has worked. And also the other is around utilizing the health facilities, especially where we have health teams who are trained, for example, in clinical care for sexual assault survivors, who are able to navigate through and be able to provide services, but also help take care of the accommodation needs for the survivors temporarily while different options are being explored. The other also is around access to mobile phones. How do we ensure that we support women and girls, even though there is a lot of difficulties around accessing mobile phones? Earlier today, I was having a call with some of the field teams, the ones who are working directly with the survivors, but also most closely with the women and girls themselves. And some of the things which came up in the discussions was coming from the communities themselves. They are proposing having toll-free lines established or installed around places which have been having women and girls safe spaces, also youth-friendly spaces, to have those toll-free lines available, and for women and girls to have access to the toll-free lines to be able to make calls to the volunteers, to the social workers, and also the staff who are able to provide the support. Of course, again, there is the challenge of remote areas where we have difficulties in accessing phone networks, but at least that is something which they have proposed, and there is an innovation, I think, a technology which they've suggested, which has worked, which links that to the first caller, at least up to about 10 people who are part of the referral mechanism. If the first caller if the first recipient of the call is not available, it automatically switches off to the second person. And that way, up to the third, someone is able to pick up the call from the referral pathway.
Dorcas, thank you so much. I unfortunately have to cut you short because we're just on time. Sorry about that. But thank you so much to everyone for a fantastic conversation. I hope you found this useful, and along with the resources that have been put in the chat box. And I'll pass it over to Paul, please.
Hi, everyone. Firstly, thank you so much. Very, very interesting and hugely important. So we're very pleased that we could have this topic on these webinar series. So thank you to Yeva and colleagues. Next week is going to be looking at nutrition and COVID-19. And then the following week, we will be looking at surveillance and COVID-19, all of course in humanitarian settings. Thank you all, and we look forward to seeing you all next week. Bye-bye.